Imagine getting like a piece of plastic implanted deep inside your body, and the doctor just sort of pats you on the shoulder and says, "It looks good. See yourself out."
Right, just off you go. No follow-up appointment.
Nothing. Absolutely nothing. But then, a few years later, a lab can't quite read your routine cancer screening, and suddenly you're forced to wait exactly 3 months.
And not a day sooner.
Yeah, not a day sooner, to test again, no matter how incredibly anxious you are about the results. It just makes you wonder, why is the medical calendar so seemingly erratic?
Well, when you actually peel back the curtain on these calendars, you realize it's actually about human biology dictating the schedule. We tend to view medical appointments as, just administrative defaults.
Right, like they're just filling slots in a schedule book?
Exactly. You assume the front desk says come back in 6 weeks just to keep their filing system organized. But that timeline is actually tethered to the physical reality of how your cells operate.
So, welcome to today's Deep Dive. We're taking a massive stack of medical guidelines, clinic protocols, patient resources, and we are using them to answer a highly specific, but honestly universally relevant question for you.
Which is, when should I schedule a post-treatment review?
Right. Our mission today is to decode the secret logic behind these dates. Because whether it's, tissue healing, systemic chemistry, or cellular replication, your calendar is actually a biological blueprint. Okay, let's unpack this, starting with the most surprising revelation from our sources.
Yeah, this was unexpected.
The treatments where a clinical review is actually not required at all.
Yeah, we're starting in the sort of DIY realm of follow-ups, looking at physical devices and implants. Think about standard intrauterine devices.
IUDs.
Right, IUDs, whether they are the copper version or the hormonal ones, and also contraceptive arm implants.
The guidelines here are incredibly clear and honestly kind of counterintuitive. Routine post-insertion checkups with a clinician are generally not required.
Which blows people's minds.
It really does.
Yeah.
You get this device placed inside your uterus, and instead of clinical monitoring, it's entirely about self-monitoring. For an IUD, you were advised to feel for your own threads 4 to 6 weeks after insertion.
And then at regular intervals after that, like monthly or just after your menses.
Right. It's so strange. I mean, it's like installing a reliable home appliance. If it's plugged in and running smoothly, you don't call the electrician back just to stare at it.
That's a great way to put it. The underlying logic is that once a device is safely situated in a stable environment, the risk of spontaneous complication just drops dramatically.
There's a catch.
There is. The sources highlight one major exception where a clinical checkup at 4 to 6 weeks is strongly recommended.
Right, and that happens if an IUD is inserted within 48 hours of childbirth?
Exactly. This is known in the clinical protocols as a postpartum intrauterine contraception, or PPIUC, insertion.
Which makes sense if you think about the physical environment, right? A standard IUD insertion is like dropping an anchor in a calm bay. Once it's set, it usually stays.
Yeah, but a postpartum uterus is not a calm bay.
No, it's like a bay where the water is rapidly draining out and the landscape is violently changing shape. You absolutely have to check if that anchor actually held.
What's fascinating here is that analogy perfectly captures the anatomical reality. After childbirth, whether it's a vaginal delivery or a cesarean, the uterus is rapidly involuting.
Which means shrinking, right?
Right, it's shrinking back to its non-pregnant size. And this massive anatomical shift significantly increases the risk of the device migrating or being expelled entirely.
Or the threads just getting lost.
Yeah, drawn up into the cervical canal where they are non-visible. So that 4 to 6 week clinical check aligns precisely with the time it takes for the uterus to finish that shrinking process.
So the doctor can actually see what the final landscape looks like.
Exactly, allowing the clinician to accurately assess if the device survived the geographic changes and trim the threads if necessary.
Okay, but hang on. I have to push back on this. You're telling me we just trust the patient to check their own IUD strings for the non-postpartum insertions?
Generally, yes.
How are they supposed to know the difference between, like, a normal Tuesday cramp and a piece of plastic actually migrating through their internal organs? It just feels like an immense amount of responsibility to place on you without a clinical safety net.
I get that, but the clinical safety net is actually front-loaded into the patient education at the very time of insertion. The sources outline very specific red flags that patients are trained to identify.
Okay, so what are the red flags?
Well, it's not just about reaching up and finding the threads. You are instructed to seek urgent review if you have persistent, severe pelvic pain that just doesn't resolve with standard painkillers.
That makes sense.
You also need to act if the threads are suddenly missing, if they feel significantly longer or shorter, or And this is a big one, if you can actually feel the hard plastic stem of the device protruding from the cervix.
Oh, wow. Yeah, that would definitely be a red flag.
Or if you experience abnormal bleeding or severe pain during intercourse.
Okay, that is a pretty robust list of things to watch out for. There's also a highly specific detail hidden in the sources for anyone using a menstrual cup, like a moon cup.
Yes.
The 6-week rule. Right. You were advised to wait a full 6 weeks post-IUD insertion before using one. And the suction of the cup doesn't necessarily pull the IUD out, but you still have to give your body that initial 6-week integration period.
Yeah, you have to let the device settle before introducing any competing mechanical forces.
Okay, so that 6-week window is a crucial biological milestone. But if physical devices like an IUD are largely set and forget locally, the rules completely invert when we change the entire chemical landscape of the body.
They absolutely do.
Right, which shifts us away from this DIY approach and into what we can call the calibration curve. We are moving to systemic hormone therapies.
Because hormones act like systemic messengers. They affect everything from your brain to your blood vessels.
So the follow-up timeline locks into a highly structured clinical calendar.
Exactly. Systemic drugs require this phased approach because we are dealing with complex feedback loops. When you introduce outside hormones, your internal organs need time to figure out what to do with them.
So let's look at hormone replacement therapy, or HRT, primarily used for menopause symptoms.
Right. The standard guideline is a clinical review 3 months after starting or changing a dose, and then annually after that.
And during that 3-month review, doctors are checking your blood pressure, your weight, and crucially, your bleeding patterns.
The sources are extremely strict about this part.
Yeah, they are. Any unscheduled or prolonged bleeding 3 to 6 months after starting HRT requires immediate investigation, usually like an ultrasound or a biopsy, just to rule out any dangerous changes to the endometrial lining.
It's a critical safety check.
But then let's contrast HRT with TRT, testosterone replacement therapy. The calendar for TRT is vastly tighter. You get baseline bloods done, then a check at just 6 weeks.
Right. Very fast.
Yeah, followed by 3 months, 6 months, 12 months, and then annually.
The discrepancy there is driven by the specific physiological risks associated with exogenous testosterone.
Meaning testosterone introduced from outside the body, right?
Correct. The primary reason for that early 6-week check on TRT is actually to monitor your bone marrow.
Bone marrow, really?
Yeah. Testosterone acts as a signaling mechanism to the kidneys, prompting them to produce a hormone called erythropoietin.
Okay, and what does that do?
It tells your bone marrow to rapidly pump out more red blood cells. So we are watching for rapid spikes in hematocrit.
Which is the sheer concentration of red blood cells in your bloodstream.
Exactly.
Wait, okay. If they are both powerful systemic hormones, why is TRT so uniquely urgent? Why does HRT get a leisurely 3-month adjustment period while TRT sounds an alarm bell at 6 weeks?
It comes down to catching an acute, life-threatening danger versus allowing time for long-term calibration. If your hematocrit levels on TRT exceed 0.54.
So 54%.
Right, 54%. The physical viscosity of your blood fundamentally changes.
So at 54% hematocrit, your blood essentially goes from flowing like water to pumping like ketchup.
That paints a really vivid, terrifying picture, but it's medically accurate.
Ketchup blood.
Yikes. When blood becomes that thick and sluggish, it significantly increases the risk of thrombosis.
Like clots.
Right, blood clots and major cardiovascular events like strokes or heart attacks. That 6-week mark is the earliest biological point where we can detect that dangerous red blood cell trajectory.
Oh, I see. So it's a timing issue.
Exactly. At 6 weeks, a doctor can either lower the testosterone dose, pause the treatment, or arrange for a therapeutic blood donation.
Like a venesection.
Yes, to thin the blood back out before your heart tries to pump sludge and a catastrophic clot occurs.
Wow. Okay, so TRT gets the early surveillance because of the ketchup blood risk. Meanwhile, HRT waits until 3 months because the focus is more on, symptom relief and cellular adaptation.
Exactly. The 3 to 6 month window for HRT is what we call achieving a steady state.
A steady state.
Yeah. When you introduce estrogen, your body's cellular receptors initially overreact. It takes roughly 3 months for those receptors to upregulate or downregulate appropriately.
Ah, so that's why side effects like breast tenderness or, mood swings or nausea often settle down right around the 12-week mark.
Spot on. If a doctor checks you at 3 weeks, your chemistry is still wildly fluctuating.
Because there's no point.
Right. By 3 months, the systemic chemistry has truly calibrated, and the true long-term effects of the dose finally reveal themselves.
So chemical treatments require this strict calendar because your entire system needs time to calibrate. But what happens when the trauma isn't chemical but physical?
Like surgery.
Yeah, when a surgeon actually alters your anatomy. Hormones aren't the primary timekeeper anymore. Tissue regeneration is. That shifts us from the calibration curve to the anatomy of surgical healing.
And the sources provide a really fascinating breakdown of this by looking closely at bladder and pelvic organ prolapse surgery.
Let's define that really quick. A prolapse occurs when the pelvic floor muscles weaken, and organs like the bladder, the bowel, or the uterus literally drop down or press into the vaginal walls.
Right, and the surgical repair involves physically lifting those organs back into place.
And stitching the deep connective tissues to provide permanent support, right? Frequently without the use of synthetic mesh these days.
Exactly.
And the recovery timeline for this follows a brilliant framework called the 2-2-2 milestone rule.
It's such a helpful way to visualize it.
It really is. Let's walk through it because if you ever undergo a major surgery, this is essentially your biological roadmap.
Let's do it.
First, you have the 2-day mark. This is when localized swelling and inflammatory responses hit their absolute maximum. The only focus here is resting flat and managing pain.
Right, survival mode.
Basically.
Yeah.
Then you hit 2 weeks. This is the first clinical check of the incisions. At 2 weeks, patients usually start to feel pretty good on the outside.
And they do, yeah.
They might want to drive short distances, run light errands, or just get back to their normal routine.
If we connect this to the bigger picture, that 2-week mark is psychologically dangerous.
Why dangerous?
Because the superficial skin incisions have closed up and the acute sharp pain has subsided, so the patient often feels functionally cured.
They feel fine.
Right. But internally, the deep connective tissues and the structural sutures holding the organs in place are still incredibly fragile.
They haven't really healed yet.
Not at all. They're relying almost entirely on the surgeon's thread, not your own tissue strength.
Oh, wow.
Any heavy lifting, straining, or sudden intra-abdominal pressure can physically tear those sutures and completely ruin the surgical repair.
So if you are sitting there at the 2-week mark after prolapse surgery, you might feel perfectly fine to carry a heavy bag of groceries. But inside, your deep connective tissues are essentially wet paper mache.
Exactly. Wet papier-mâché.
Here's where it gets really interesting. It's exactly like renovating a house.
Oh, I like this.
Yeah, think about it. You pour a new concrete foundation and slap up some drywall. At 2 weeks, the paint looks dry on the surface, and the house looks finished.
Right.
But the foundation underneath is still curing. You can't throw a massive house party with 100 people jumping up and down just because the living room looks nice. The floorboards will literally cave in.
You have to wait for the foundation to fully cure.
Exactly.
In human biology, that structural curing happens at the final milestone, which is 2 months or roughly 6 to 8 weeks.
Okay, the 2-2-2 rule. 2 days, 2 weeks, 2 months.
Exactly. This 2-month mark is the major clinical checkup. Over those 8 weeks, your body goes through an intense process of collagen remodeling.
Collagen remodeling, what does that actually mean?
It means it dissolves the surgeon's internal stitches and replaces them by laying down strong, mature scar tissue over the surgical sites.
So it replaces the thread with your own structural tissue.
Yes.
And it's only this 2-month mark that the lifestyle restrictions are finally lifted. Patients are cleared to fully resume normal activities.
You can lift things heavier than 10 to 15 pounds.
Which, the sources helpfully note, is roughly the weight of a gallon of milk in each hand.
A very practical metric.
Very. You can take baths again, go swimming, and safely resume sexual intercourse.
So that 6 to 8 week review isn't just a date a surgeon pulled out of thin air. It is the precise biological timeline required for deep fascia and muscle to synthesize enough collagen to knit back together with sufficient tensile strength.
Tensile strength.
Yeah, it takes 8 weeks for your own tissue to be strong enough to withstand the normal intra-abdominal pressures of coughing, lifting, and just daily life.
It really is a masterclass in human biology. You are literally just waiting on your own cells to... It is. So we've gone from local devices to systemic chemicals to physical rebuilding. But the final stack of guidelines here enters a totally different arena.
A much more intense arena.
Yeah, we aren't just waiting for healthy tissue to knit back together anymore. We are racing against rogue cellular replication. This is high-stakes surveillance.
We're moving into the realm of oncology and cellular abnormalities.
Right, focusing heavily on cervical screening and gynecological cancers.
In this arena, the calendar is aggressive because early detection is really the only metric that matters. These are arguably the most rigid follow-up timelines in medicine.
And the anxiety around these specific timelines is palpable for anyone who has been through it. Let's look at standard smear tests or, cervical screenings.
Okay.
According to the guidelines, if a sample is deemed inadequate, meaning the lab couldn't get a good, clear read on the cells, the repeat test is scheduled for exactly 3 months. Never 6 months, never 2 weeks.
Right.
But if you test positive for high-risk HPV, but have normal cytology, meaning the virus is present, but the way the cells actually look under a microscope is perfectly fine, you are invited back for a repeat test in 12 months.
The logic driving every single one of those intervals is tied directly to the life cycle and regeneration speed of the cells in question.
Okay, but hang on. If I go in for a smear test and I get a letter a week later saying the sample was inadequate, that is terrifying.
Of course it is.
I'm naturally going to assume the worst. Why am I forced to sit at home and stress for exactly 3 months? Why can't I just, march back into the clinic the next morning and do it again to get peace of mind?
It is entirely counterintuitive from an emotional standpoint. I completely agree. But biologically, the wait is mandatory.
Because of the cells.
Yes. When a clinician takes a cervical sample, they are physically scraping off the top layer of epithelial cells from the cervix.
Okay.
If you go back the next day or even a month later, that top layer hasn't had time to regrow.
Oh. So there's literally nothing to test.
Right. If they scrape again, all the lab will see under the microscope is localized inflammation, repair cells, and blood. It takes a minimum of 3 full months for the cervical epithelium to fully regenerate a mature layer of cells that can be accurately and safely analyzed for precancerous changes.
So doing the test any earlier guarantees another inadequate sample.
Exactly, which just resets the clock and prolongs your anxiety even further.
Wow, the cells physically aren't there to be tested yet. That makes perfect sense, even if the waiting is absolutely miserable. And this cellular timeline dictates the treatment side too, doesn't it?
It does.
The sources mentioned a test of cure at 6 months for patients who undergo treatment for abnormal cells, like a LLE-TZ procedure for CIN.
Yes, the 6-month wait.
Just to clarify the medical alphabet soup there for a second, CIN is basically the medical term for precancerous changes on the cervix, and LLE-TZ is a procedure that uses a tiny heated wire loop to safely remove those abnormal cells before they can turn malignant.
That's right.
So you get that done, you're relieved, but you still have to wait 6 whole months for the follow-up.
And that 6-month mark allows all the thermal damage from the heated loop to completely heal.
Okay.
And, crucially, it gives any microscopic rogue cells that might have been missed enough time to replicate to a detectable level without giving them enough time to actually become invasive cancer.
It's such a tightrope walk.
Yeah.
But what about when a cancer has actually fully formed and been treated? The sources go into heavy detail about endometrial cancer, which is cancer of the uterine lining.
Right.
After a patient has a hysterectomy to remove the uterus, there is a fast follow-up at just 3 weeks to discuss the histology results from the lab. But then the patient enters this incredibly intense surveillance protocol.
Very intense. Checkups every 3 to 6 months for the first 2 years, and then every 6 months up to 5 years.
Yes.
The underlying logic of that intensive 2-year window is purely statistical. It's driven by tumor biology.
Oh.
If endometrial cancer cells were microscopic and managed to escape the surgical removal of the uterus, they can sometimes regrow.
Even without the uterus there.
Yes. And if they do, it is most commonly at the top of the vaginal canal, an area known as the vaginal vault. Statistically, this aggressive vault recurrence is overwhelmingly most likely to happen within the first 24 months after surgery.
Hence the intense 2-year window.
Right. The calendar is aggressive because catching that localized recurrence early is the difference between a highly treatable issue and a life-threatening systemic crisis.
The sources also highlight a very specific and frankly quite intense protocol for patients who undergo cervical brachytherapy.
Which is a highly targeted type of internal radiation therapy.
Right. The guidelines emphasize an additional specialized 30-minute review strictly between 6 and 12 months post-treatment. And this appointment isn't just to check for cancer recurrence.
No, it's not.
It's specifically to monitor the patient's use of vaginal dilators and check for adverse anatomical reactions from the radiation.
This raises an important question about balancing cancer eradication with quality of life. Radiation is incredibly effective at killing cancer, but it causes the surrounding healthy tissue to contract, thicken, and scar.
It damages the good stuff, too.
Exactly. This can permanently narrow or shorten the vagina, making sexual intercourse or even future life-saving medical exams incredibly painful or physically impossible.
So that's where the dilators come in.
Right. Vaginal dilators prevent this by mechanically keeping the tissue stretched, but they require strict daily compliance from the patient.
And this 6 to 12-month check.
That check is crucial because it's the exact window where that tissue fibrosis, the scarring, is actively occurring.
Oh, I see.
If a doctor catches the contraction then, medical intervention can still preserve function and quality of life. If they wait 2 years, the tissue changes are often permanent.
That is heavy, but it makes so much sense. Every single appointment on that calendar is a calculated move in a biological chess game. So bringing this all together for you listening, post-treatment reviews are truly a hidden masterclass in human biology.
They really are.
Whether it's your uterus shrinking back to size post-childbirth over 4 weeks, your blood dangerously thickening from testosterone in 6 weeks, your deep fascia laying down mature scar tissue at 8 weeks, or your cervical cells slowly regenerating over 3 months.
It's all connected.
The calendar is never just administrative. It is always dictated by the speed of your cells.
It is entirely driven by biological reality. But, as we look to the future, there is a fascinating shift on the horizon that builds on everything we've discussed today.
Oh, what kind of shift?
We are rapidly entering the era of continuous real-time health monitoring.
You mean like the explosion of wearable tech, smartwatches, at-home biometric rings, that sort of thing?
Precisely. Right now, we schedule a checkup at 6 weeks after surgery or starting a hormone because that is the statistical average for tissue healing or hematocrit peaking across millions of people.
Right, it's an average.
But you are not a statistical average. You are a biological individual.
That's
What happens when your wearable device can continuously monitor your internal inflammation markers, your localized body temperature, or your hemoglobin levels in real time?
oh, wow.
Will the traditional 6-week checkup become entirely obsolete? Will your devices simply ping your doctor the exact moment your personal internal healing reaches its biological finish line, whether that takes you 4 weeks or 9?
Wow. We go from a statistical guess to absolute personalized precision. It really makes you wonder. We started this deep dive talking about how the post-treatment landscape feels erratic and murky.
But maybe it won't be for long.
Yeah. With that kind of technology on the horizon, the calendar of the future won't be a calendar at all. It will just be a real-time conversation between your tech and your doctor.
It's a pretty wild thought.
It is. But until then, respect the dates you were given, because they're respecting your biology. Thanks for taking this deep dive with us.